Hi, good afternoon, everyone. So excited to have you here at For Us by Us, Black Voices on Freedom from Tobacco. I'm so excited to have you. I'm host Dr. Kendra Darty, serving as the Vice President of Engagement and Outreach at Truth Initiative, the nation's largest nonprofit dedicated to nicotine-free lives. And with our amazing host, NAACP, for this session and webinar around Black Voices from Freedom from Tobacco. And so we're going to go ahead and get started. We're going to let all the panelists introduce themselves. And so we'll first start with Maham Akbar.
Hey everyone, good afternoon or good morning, depending on where you're joining us from. I'm Maham Akbar. I'm Managing Director of Public Policy at Truth Initiative.
Dr. Chris?
Good afternoon, everyone. Dr. Chris Purnell. I am the director of the NAACP Center for Health Equity. Very excited to be a part of this dialogue today and how this will empower our actions.
Awesome. Thank you so much. So glad that both of you are able to join today's webinar as a panelist. Can we go to the next slide, please? So a little bit about who we are at Truth Initiative for those who do not know, and a little bit more. Truth Initiative is, of course, the nation's largest and America's nation's largest nonprofit public health organization dedicated from freedom from nicotine addiction. And so we've been around for over 25 years, really focusing on this particular area and effort. And so we have made great strides, but we are continuing here at Truth Initiative to anchor in cultural competency as we move health equity in the lens of that to the nation. And so this particular program is a part of the Cultural Cessation Collective, which is an overall initiative of my teams to really focus on disparities really raised in African Americans. And so we will pass it over actually in our next slide to NAACP to talk about who they are if you don't know as well.
Thank you so much. So the NAACP, many of you are familiar with a cultural institution in the United States and more broadly advocating around the civil and human rights for historically marginalized groups in all populations to be able to protect their franchises. But the Center for Health Equity specifically is committed to driving equitable health outcomes and transforming healthcare systems through a comprehensive socioeconomic approach that values the whole person. What does that mean? It means that equity is the equation, if you will, for justice. And that as we work to advocate for, to catalyze, to agitate, to fight for health and racial justice, we see equity as the foundation, if you will, upon which that happens. And so equity then drives transformations of healthcare systems as well as individual and population level health outcomes. Back to you.
Thank you so much, Dr. Chris. What a great example of what all the work you're doing at NAACP and really understanding that a little bit more. And so we're going to go ahead and dive into the conversation today. Everyone really focusing right now on Truth Initiative and our particular part and to really just set the stage about why we know it's important to focus on Black lives particularly. So the history of the tobacco industry is targeted Black communities for generations. Tobacco companies have placed more ads in predominantly Black neighborhoods. We have seen Black youth are 3 times more likely to recognize Newport menthol ads and other ads. And then also we see that in Black communities, they have lowered prices and create more promotion opportunities where Black populations are higher. And so those who you clearly see from the demonstrations of some of the ads that we've synonymous in Black culture, really looking at what they have done and how they have really sponsored a lot of Black cultural events, and particularly looking at how they are really have embedded themselves as a funder of Black activities and engagement across this country. And so we want to just level set and give that information to you, a little bit understanding about why we know that we must have programming like this today to really counteract the activities of the tobacco industry particularly. Next slide, please. And so where we are today and the impact, we know that 45,000 Black Americans die from smoke-related diseases each and every year. Let that sit for a second. 45,000 Black Americans die each year from tobacco and smoking related diseases. And so Black Americans are also more likely to be exposed to secondhand smoke exposure. They might not particularly utilize the product, but they are around it and amongst people who do in their homes and in their environments. And then also we know that 80.9% of Black American smokers use menthol products and menthol cigarettes. And so menthol makes cigarettes easier to smoke and harder to quit. And we know that from the data and science here at Truth Initiative and research across the country, particularly knowing that the tobacco industry has predatorily gone after African Americans by giving them and really embedding mentholated products into their respective communities. Next slide for me. And so, in regards to where we are today and the impact of that, so we also know that smoking drives heart disease and cancer as the top cause of death in Black Americans. And really understanding that and really taking root and understanding that we would think there's so many other disparities that rise up in the Black community, but understanding that the common cause of this is smoking. And that we're driving the health impact of this particular statistic. Then we also know that 72,000 diagnoses and 39,000 deaths from tobacco-related cancers caused each year. And so really understanding that in Black African Americans or Black Americans experience higher secondhand smoke exposure, like we said, indicated earlier, but really just looking at those figures and really saying, okay, we know this, and what can we do? And so we're going to move the conversation forward today to really understand the impact of these diagnoses and these deaths and what we as a community can do for us, by us, to really improve health outcomes for African Americans in this country. Next slide. So I'm going to pass it on to our Director of Public Policy, Maham Akbar, to talk a little bit more about tobacco control infrastructure. Maham.
Thank you. Thank you, Dr. Dartis. I'll lay out the policy landscape and where there's progress being made and where the gaps are and what you all can do in your communities. So let's start with what's been lost. This year, as you all probably know, has been particularly rough for public health, and tobacco control was especially hit hard. On April 1st, the CDC Office on Smoking and Health was completely eliminated. And there were also sweeping cuts made at FDA's Center for Tobacco Products. So many foundational systems which support tobacco use prevention, cessation, research, and public education have been substantially reduced or eliminated entirely. And so these cuts were made to the agencies that regulate tobacco products and also monitor and attempt to reduce tobacco use. And these cuts have been called a gift to big tobacco. And so while many staff have reportedly been reinstated at FDA, though it's still unclear to us exactly who, CDC OSH remains eliminated. And while these cuts were really made to reduce federal spending, it's actually going to have the opposite effect. Because we know cigarette smoking costs this country more than $240 billion in healthcare spending, and nearly $185 billion in lost productivity from smoking-related illnesses and health conditions. And so the programs that are at CDC's Office on Smoking and Health, they really played this critical role in preventing youth tobacco use and helping adult tobacco users quit. And so programs like the Tips from Former Smokers, which is a public education campaign encouraging people to smoke, to quit. And it featured real people living with serious long-term health effects from their smoking and secondhand smoke exposure. So we've lost that. CDC OSH is also the only federal agency that provides funding and technical assistance to state health departments for tobacco control efforts. And so while state programs did receive funding in October for the fiscal year 25. That grant remains in jeopardy, and we don't know that it'll continue past April 30th. And so also, while many of the staff at FDA's Center for Tobacco Products, as I mentioned, were reinstated, FDA hasn't been transparent or stated publicly where when those staff have been reinstated. And so if there are less staff at FDA Center for Tobacco Products to enforce the current regulations that we do have, it's likely that this will result in more tobacco products coming onto the market, and almost no new regulations will be issued to further the mission of reducing tobacco-related death and disease. Next slide. And so really looking at the federal landscape about where there's progress, where there's gaps. One huge gap is that a few days after he took office, the Trump administration rescinded these final rules to ban menthol cigarettes and flavored cigars. And as Dr. D'Artise mentioned, those are rules that really impact the Black community in particular. And so these were proposed rules that the FDA had finally issued and had taken more than a decade to get in the making, and it included health groups actually having to sue the FDA for taking so long and not acting. And so at best, these rules are not going to sit on a shelf at FDA for the next few years. The next one is at the very end of its term, the Biden administration and FDA issued a proposed rule to reduce the addictiveness of combustible tobacco products to non-addictive or minimally addictive levels. And this really has the potential to be a significant and momentous game changer. There's currently no limit on nicotine levels in the US at the federal level for any tobacco product, and particularly for combustible products, which have the most harms. We know nicotine is highly addictive, and it's what keeps people coming back to the products for more. And so a person needs to use more and more nicotine to get this reward and to ward off withdrawal symptoms. And so while nicotine itself isn't the cause of much of the health problems associated with tobacco use, it's not entirely harmless, and especially when it comes to young people. In young people, we know that the earlier one starts using nicotine, the harder it is to quit. Nicotine can also harm the developing adolescent brain. It has an effect on concentration, learning ability, mood, and impulse control. And so given this massive public health burden of smoking, this proposed rule will have this great unprecedented benefit for society. So this is a rule we greatly support. We'd love to see FDA finalize it quickly, but that doesn't appear to be the intent of this administration. Now, there is at least one good thing happening at the federal level. They are taking more and more enforcement actions against what are called illegal e-cigarette products. So there are only 39 e-cigarettes that are authorized to be sold in the US, and FDA has made it clear that those are the only e-cigarette products that can be lawfully sold. And so when I say illegal e-cigarettes, that means anything that has not been authorized by the FDA to be sold on the market. And the majority of what's being sold in the US marketplace is all illegal e-cigarettes, and they're continuing to flood the market. So the e-cigarette market is constantly evolving and adapting to keep existing customers and to attract new users. E-cigarette devices have changed drastically since they first came on the market in 2007. And so the current state of the e-cigarette market is that it's dominated by what are called disposable products. And these products have gotten bigger, stronger, and cheaper, and they deliver more nicotine at price points that are more accessible to young people. And so it's great that FDA has begun ramping up compliance and enforcement efforts across the supply chain. So they're targeting manufacturers, distributors, and retailers. In September of this year, FDA worked with other agencies and announced they seized $86.5 million worth of illegal e-cigarettes, which was their largest ever seizure of that kind. FDA is also encouraging retailers to stop selling illegal e-cigarettes. And then to the last point here, nicotine pouches and what's going on there. So earlier this year, FDA authorized 20 Zyn nicotine pouch products, which was the first time they had authorized any nicotine pouches to be sold in the US. And they also in September announced that they were launching a pilot program to more efficiently review what are called pre-market tobacco product applications for nicotine pouch products. However, there's little information that's been made available about this pilot program. And so we at Truth Initiative, along with other public health groups, want to make sure that this program maintains that kind of rigorous scientific review that the law requires, and that's necessary to protect the public health from the risks of new tobacco products like nicotine pouches. Next slide. So we know there's a little bit of good happening at the federal level, but there's definitely a lot more gaps than there is progress. We know that the federal regulatory process moves incredibly slowly, but action at the federal level is not the only option, though it certainly would be the best and most comprehensive. There's a lot that states and localities can do, and they don't have to wait for the federal government to act here. The impact of tobacco products in our communities is very real, and there's policies that can reduce that impact of tobacco in the retail environment. So these include things like prohibiting the sale of flavored tobacco products, including menthol cigarettes, increasing taxes on tobacco products, requiring a license for tobacco retailers to be able to sell tobacco products, prohibiting the sale of tobacco products, including those with very high nicotine content, limiting the sales of all tobacco products to adult-only stores, prohibiting things that make these products cheaper, like couponing and other discounting tactics, and then also setting minimum prices for tobacco products. And then there's much, much more. There's a great evidence base for policies that actually work to reduce tobacco and its impact. And I'll turn it over to Dr. Dartis now, who can speak about our cessation program.
Yeah, thank you so much, Mahan, for that very comprehensive step-by-step around what's going on in the current landscape. And so one of the things that we do here at Truth Initiative and have created in partnership with the Mayo Clinic is the X program, which has helped millions of people build skills and confidence to successfully quit. And so from this is a free digital quit programs. Quit is another way to say cessation. Cessation is another way to say quit, and really helping support our 8-week intervention program to really text and being able to communicate with you to make sure that you quit and give you resources and really encourage you in a positive, uplifting manner. And so the X program research shows that it has increased the odds of quitting by up to 40%. And so we encourage those. I think we dropped in the chat, particularly around the X program. We wanted people to know there is a free digital quit solution that you can just text, or being able to just going online and register to communicate directly with it, and it'll be able to give you the prompts and necessary steps in order to quit. And so we wanted to know that we understand and recognize the impact the landscape. We understand the impact of this particular of nicotine in the African American community, but we know at Truth Initiative we have provided a solution to help the community really take hold of this particular issue. And so with that, I wanted to go ahead and turn it over to NAACP's director, Dr. Chris Purnell. Dr. Chris.
Thank you, Dr. Dartis. Very, very excited to be able to add to the conversation. So, you know, a little bit about, I think a lot of it, but a little bit about who we are, the NAACP. You can go ahead and go to the next slide. I think it's so important to understand how the fight for health justice is intimately aligned with the fight for racial justice. And so the Center for Health Equity is girded and guided by strategic priorities, or what we call our health equity pillars. The work that we do in the center is around equitable access to quality health care and equitable health outcomes. So think about all that we are talking about currently in the national dialogue as it relates to Affordable Care Act tax credits, Medicaid, as well as the disproportionate burden and impact that we see on Black birthing people with the disproportionate and unequal rates of maternal mortality in the Black community. So when we talk about that and that pillar, that's what we mean. We also work around equitable food systems. We know that food and nutrition is the floor, if you will, of being healthy, of thriving, of whole person wellness and well-being. So whether it's advocacy advocacy related to SNAP, or whether it is elevating food literacy and ensuring that there is social and cultural fluency when we talk about food and nutrition. That's the work of the center. Also, we work around inclusive healthcare systems and infrastructure. It's very important that we in this country realize that I'm of the 3%. And you might say, Dr. Chris, what's the 3%? Roughly 3% of physicians in the United States are Black or African American women. And we know that we see equitable health outcomes when we have diverse and inclusive training populations, diverse and inclusive workforce, and a diverse and inclusive system that considers the assets, the needs, the priorities of multiple communities, especially those who are historically excluded and marginalized. And finally, healthy people, healthy communities, and health in all policies. That is what I call our, in the words of my mother, it's so wide you could drive a Mack truck from it. My mother was from Virginia, and that was one of her favorite sayings. Like, it's so wide you could drive a Mack truck through it. This is our bread and butter public health pillar, and where we're talking about issues around, nicotine cessation, around promoting how to prevent tobacco use, how to successfully quit, and then aligning those, let's say, issue spaces with policies, aligning those issue spaces with the other pillars that we have just described. Next slide. So how does that work come alive? You just heard about our 4 strategic pillars, but the how of what the NAACP model is a 7-point advocacy model. And that advocacy model in and of itself is robust, it's comprehensive, and it is inclusive. And this is how we work in tandem. I am in the national office, but we work in tandem with our units. We have over 2,000 units or branches, as they are called, across the United States. We have units that are focused on the youth and the college division. So we work with youth councils, we work with college chapters, we have state and area conferences so that we can do more drill down regional work in frontline communities. And we do it using these tools or using these principles: centering equity, advocating. So as we're advocating around tobacco control issues, we're centering equity, that we're disrupting systems where there are opportunities for litigation. The NAACP is partner 2, or is the lead on litigation. We build knowledge through research. You just heard some of the outputs or the outcomes associated with the X program, and that becomes collective understanding. But we also want to add to the knowledge that we know, not just about this issue space, but across the gamut of issue spaces. And then there's training, right? Expanding leadership, convening. We have our monthly Health Leads forums, and Dr. Dartis has been one of the guest presentations on that forum. It is an opportunity for our frontline leaders that are specific to the health and well-being space to engage, to connect, to collaborate, to hear from, and as I like to say, to collide up their thoughts, to collide up against one another, to produce bold new thought and action. And definitely we use storytelling to change and shift the narrative, right? I have always resorted to storytelling, whether it's about my personal story or that it's about once being uninsured. Yes, I was a young physician, just finished Duke Medical School, unfortunately got very sick from POTS and became uninsured. And so we use storytelling as a way to understand, to help people connect the dots to why an issue matters and how it might impact them or their community, and then the potential solutions around that. And finally, mobilize, 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 mobilize. And you will see me describe many of these 7 points in our subsequent slides. But I thought it was really important for those on this webinar and for all of our partners in this stew, right? This health equity stew, to know how we get the work done. Next slide. So that takes us specifically to the Enough is Enough Take Down Tobacco campaign, or as it is abbreviated there, TDT. So I've been with the NAACP almost 2 years now. In February, we'll make 2 years. I'm a public health and preventive medicine physician. I love public health. Perhaps you hear it in my passion when I speak. And so when I think about public health and prevention, the power of prevention, I really think about outside of the four walls of healthcare. And I think about how public health and even population health or community health happens on the front lines of community in our neighborhoods. So we have focused in the association and specifically the center around the issue of tobacco because we're looking at ways that will drive collective impact, meaningful impact, and the bottom line, save lives and improve health outcomes. And it is impossible to do that without focusing on the use of tobacco products. And so sometimes people even say, hey, why are we always talking about this issue? Because if we're going to save Black lives, and we have to talk about the things that are driving the disparities or the negative health outcomes. So this is why we took this campaign to our front line. When those federal lanes close, and thank you for Mahan explaining a lot of what we're encountering and we're facing. But when those federal lanes closed, right, a change in administration totally demonstrates the political determinants of health, how politics, how that impacts a political or a policy agenda. We had to figure out a way to do what? Continue to save lives and improve health and well-being. So we partner with the engine of the NAACP Association, our branches, our youth councils, our college chapters, and our state and our area conferences. In this iteration of this campaign, we offered an opportunity for these frontline leaders to take on the issue either in their state or to take on the issue in the locality where they lived. And so as you can see across the United States with another one of our partners in the tobacco control space, we looked at where there were either active issues in a local council or an active issue at a state level that we wanted to educate around. Think about that 7-point advocacy model, right? That we wanted to educate around, inform around, tell stories around, mobilize around, convene around, and then drive outcomes. And so this is why or how we arrived at the locations that you see here. It's a fair amount of diversity geographically. We were out west in Washington. We were in Colorado. We were in the Northeast, whether in New York City or in the Maryland area, so the Northeast/Mid-Atlantic states. We were in the Midwest in both Cincinnati and Milwaukee, and we were in the South. We had opportunities in Richmond. My family, I told you about my mother. I come from a family that farmed tobacco, right? We talk about the realities that these communities face. And I recall my father's father, he wasn't the side of the family that farmed tobacco, but he was one of the first faith-based communities in the South that started to say before that seminal report in the 80s that tobacco was causing cancer. And so imagine when this man said this in the 60s and the 50s, and people were like, but you're coming up against the local economy, or big tobacco was seen even as, let's say, not penetrable, that it could not be taken on. So I just wanted to elevate that to show the types of things that shape how we go about to advocate, agitate, and ultimately change lives. So next slide, we can get into the specifics of where we were in those particular places. So we were in Honolulu, right, Hawaii. And so our local branch, the Honolulu branch, was one of the sites that participated in this campaign. I'll review some of the activities that they did, but they were able to work in a very hyper local fashion around the issues that were relevant. There were activities that centered youth, explaining the harms related to vaping. There were activities that were policy focused, conversations with policymakers around opportunities to curtail the access to menthol tobacco products in particular. I spoke about being in Colorado. It was actually the state area conference that was working in collaboration with the local branch in Denver, and a little bit, let's say, a little bit more broadly. We even had conversations about Aurora too, to think about, how does Denver continue to advance the ball around tobacco control issues. In the NAACP Alaska, Washington, Oregon State Conference, we were specifically active in Washington, and that was at a state level. And so I really want to show you that flexibility to focus in a very hyper-local fashion like Honolulu or Denver, but also to draw back and to think about the issue from the aspects of a state, like what is happening across the state. Is there an active issue in the state legislature? Is there an opportunity to advocate for an issue or a policy that will have a broader impact outside of a specific municipality? And it was that diversity of levers, if you will, that will allow us to describe some of the outputs that I'll get to. And so I just wanted to highlight those key sites for you. And these were our adult branches, okay? So these were activities that the focus was still the adult branch or unit, and the issues were from a more global population scale and lens. But if you go to the next slide, we focus deeply, deeply, deeply with our youth. And I was amazed by what youth were able to achieve. You share information with them, you help to build collective knowledge, and then allow their creativity, allow their sense of innovation to really come to light and to drive meaningful impact and change. So once again, we were in those same similar places that we had defined as priority geographies. And we approached several youth councils in Georgia, both the Albany, Daugherty, and the Fayette County. We looked at our assets among our youth councils, which had strong leadership, strong advisors. Sometimes it was the count, meaning how many people were involved with that particular youth council. And I'm giving you these ideas so that you can see how to replicate some of these opportunities. And so we thought about where there were relationships, sometimes relationships with local school districts, relationships with local elected officials, relationships with local health departments that could help amplify, convene, and then help to generate a very vibrant, let's say, a policy and solution dynamic, right? So that there is a connected activity on the other side of that convening. In Georgia, we worked with Georgia Southern University. That blew me away. It's like when our college students were very eager to speak truth to power, to do it in language that was authentic, to be able to explain real world impacts, to be able to describe the dynamic in the college campus around some of these issues, to incorporate data and stats, and to do it in creative ways. Our Detroit Youth Councils is one of the largest youth councils that we have in the United States, and they immediately got into action and the things that they were able to do in Detroit. And so those are just examples of other youth councils and or college chapters there on the right side of that slide. So 2 in Michigan, Detroit, and Port Huron. In Port Huron, I just want to call out, they testified before the local city council. I've done this frequently in public health throughout my training and my career, where you share information and power with your youth leaders and then allow them to speak in ways that are authentic, in ways that are impactful before decision makers. And they made it plain. They made it plain the risks that they face. And I was very, very proud to be a witness, if you will, of their activities. Equally, back in Maryland, we had 2 college chapters that were very active: University of Maryland Eastern Shore and Morgan State. They filmed PSAs, they did questions, they were popping up on people in different gathering places, professors, students, asking them what they knew about some of the harms associated with vaping and other tobacco products. And I was just so enthused about the next generation of public health scholars and leaders that are making a difference. And finally, our Washington County Youth Council, a newer youth council, but one that wanted to take on the charge and the call. Next slide. So specifically, what did they do? In this campaign, we gave them 4 activation lanes, if you will. We wanted to have them create communications that could either use the data or the stats that were made available to them, elevate storytelling. Remember that 7-point advocacy model that I showed you, elevate storytelling to people who both needed to be informed, right? So the goal was to raise awareness, help to cultivate some literacy, as well as speak to an audience of stakeholders, and whether those stakeholders were policymakers or other leaders in community. So across 8 youth units, our NAACP peers engaged 7,773 people through digital communications. Across our 6 adult units that were active at the time of this reporting, they engaged 15,193 NAACP members and community stakeholders through digital communications. Issue advocacy with policymakers. You heard me speak about the Port Huron Youth Council. Our youth units engaged 22 elected officials at every level of government. And sometimes this was just sitting down and saying how important the issue was to them. It may not have always been tied to a specific piece of legislation, right? And just raising policy issues for policymakers. But it was saying, look, this issue is important to me, and this is why this issue matters, and this is how it's impacting my community. And to see them develop that skill at that age was just brilliant. And finally, our adult units engaged 27 elected officials in 5 priority geographies. So whether those were governors, those were local representatives, those were state representatives, those were federal representatives, meaning congresspersons, our people got busy. And then they convened community forums, right? The youth-led community and unit meetings reached over 4,300 participant views or in-person attendees. We gave them the flexibility to do things virtually. So for instance, at Georgia Southern, they had over 1,000 participants on their live. We did a live with Morgan State around this issue. Our adult-led forums reached approximately 15,079 participants virtually or in person. There's an asterisk there because a couple of our New York meetings, we still didn't get the data around. So that number is actually higher, right? And then finally, their storytelling was really pulled out in very creative ways. And to say, how do you put power behind storytelling to either impact a health-seeking behavior, to impact another behavior, meaning to influence prevention or to influence cessation. And so 3 of our youth units and 1 adult unit, they chose to do a PSA. There will come a day when all of this will be documented on the NAACP website, but dare I say, I was enthused, I laughed, I pondered. They were very creative around these PSAs. And then 7 youth units and 5 adult units executed social media campaigns. So whether they had graphics that they were, tracking and communicating across their socials, or whether they had questions that they were asking people and having them respond, like putting their PSA on their social media platforms and then invoking broader conversations and dialogue that way. 2 adult units drafted op-eds. And so taking their position to that next level. So these are tools that I'm listing for people: PSAs, social media campaigns, right? We know the power of social marketing and public health, op-eds, right? Convenings before policymakers. So testifying before city councils, testifying before state legislatures. We did that in Washington as well. And finally, 2 adult units joined either a local cable, or radio station broadcast. I don't have the impressions or the streaming numbers, but between Cincinnati and New York, people just got creative, right? And even in Cincinnati, they hosted a mayoral forum, and they were able to include questions related to tobacco control advocacy issues in that mayoral forum. So it was an awesome opportunity to help lead, guide, convene, and direct these activations across the nation in a very strategic and priority focused way that you just saw. It was amazing to witness and to be partner to the creativity of others in enacting solutions. And the work does not end. The work continues. Thank you. Next.
Thank you so much, Dr. Chris, for that well-documented way of how NAACP is changing the landscape and really giving resources and empowering the community to take effective change themselves. As we open up discussion, that the Q&A portion is now commencing, and you can feel free to put your questions in the Q&A section of the webinar setting to kind of get us kicked off in a conversation around just the Black health and particularly tobacco as an intersection of that. And so we cannot talk about Black health. We can't talk about mental health. And so, Dr. Chris, as a physician, I want you to kind of take this first stab at this question to have a understanding, and then we'll lean the question into policy for Mahan to jump in. And so, how does tobacco use intersect with mental health, stress, and social conditions that disproportionately affect Black communities? And then also, if you could talk about how to normalize or destigmatize the conversations in Black households.
Yes, I love that the end part of that question. And I'm actually going to start with storytelling. You all heard me clearing my throat, right? Look, I'm about to be 50. I don't hide it. So I was a child of the 70s and the 50s, born in 75. My dad smoked, right? I told you that I had a portion of my family that farmed tobacco. It wasn't my father's family that farmed tobacco, but he always would say to my siblings, he would say to I have siblings that are 10 years plus older than me, being socialized in the Richmond area in the 50s. And this is his language, right? And I want us to be very clear on this. He's like, I thought I had to smoke to get a girl, right? So think about imagery. Think about how imagery appears in our communities and how there are triggers and cues that norm certain behaviors and they tie them to social interactions. I think it's very important that I start there because my father would be keen on saying, that's what I thought I had to do. And so I found myself starting a habit with a social goal or a social agenda. And then I got addicted. I got hooked. I watched my father go through hypnosis. I watched my father go through the gum. I watched my father go through the patch and continually struggle with tobacco use. And he smoked in the house when I was a kid. And so I started to develop chronic bronchitis as a child. And it even led to an issue around absenteeism from school. I think it's so important that I tell you that story that way, right? Because there are so many issues there. When we talk about tobacco use, sometimes we jump to the end symptoms. And I want you to step back and to think about the community and the social dynamic that influences tobacco use. And then I want you to think about how we can begin to confront those dynamics and then to change it. In our household, so now we're in the 80s into the 90s, the big conversation was limiting where you smoked in the house. So my father would smoke in the bathroom, or my father would smoke in the car with the window down. We know that that did not decrease my risk of developing chronic bronchitis because of my exposure to secondhand smoke. Okay. My father is no longer with me. He ultimately succumbed to COVID. My father lived with chronic HIV/AIDS, and my father had severe emphysema. He was diagnosed with emphysema in the 80s and lived through it and had so many, at the time, groundbreaking medical interventions to try to salvage lung tissue. And so we know that when a person uses tobacco products, that those products impact not just the lung. We know that those products can also impact mental health. We know that those products can impact cardiovascular or coronary. We know that those products basically impact every cell in the body. There isn't a cell in the body that is not impacted. It drives risk associated with cancer. It drives risk associated with cerebral vascular events like strokes, right? I say that to say, while we know how smoking drives certain health outcomes, we need to equally focus on what are the decision points that a person makes to either engage in smoking behavior, right? And how can we modify or influence those decision points so a person does not initiate tobacco use? And then what are the resources or what are the access issues that are important to say how easy is it to get care around these issues? We know that in historically marginalized groups, and specifically to talk about the Black and the African American population, it's not an accident that Black people smoke menthol products, right? There has been predatory marketing in big tobacco to focus on certain communities, to hook successive generations into a harmful behavior in order to drive an economic goal. And so I say that also because we know that there are mental health stressors or mental health conditions that might predispose or influence how a person negotiates that decision point, right? If you're stressed out and you're looking for ways to alleviate the stress, you may resort to a nicotine product in your thinking or a rationalization of it, right? To help you to treat the stress. So you're saying, I'm treating the stress by using this tobacco product, right? And so increasingly, we have to elevate conversations around whole health so that people understand what they're experiencing, whether it's anxiety, whether it's a mood disorder, whether it's toxic stress to the community stressors. Racism is a community stressor. Poverty is a community stressor. Violence is a community stressor. Trauma is a community stressor, right? So to help people understand the triggers that exist in environment, and then through literacy, cultivating understanding of more healthful ways to deal with those issues that might be driving those behaviors. So I'll pause there, but just wanted to take a stab at that question that way.
Yeah, thank you so much, Dr. Chris. What a great way to really bring it full circle. Um, really moving on to Maham and really talking about policy as a perspective, really understanding what policy changes, local or national, do you believe would make the biggest difference in reducing tobacco-related disparities for Black Americans?
Yeah, that's a great question. As Dr. Chris said, menthol is really what the menthol cigarettes are the products that are most affecting Black Americans. And so while a menthol policy, removing menthol from cigarettes is stalled at the federal level, there are lots of communities that have passed policies that take menthol cigarettes off the shelves. And there are other communities that are currently working on it. And so, policies where you're removing those types of flavored products that are really appealing to especially young people and denormalizing these tobacco products in the retail environment, those types of policies are really going to be the most effective. Policies also making the products less addictive. So the proposed rule that FDA has to make combustible products less addictive or minimally addictive, reducing the nicotine content. Those types of policies are what will really be comprehensive and should be comprehensive and would make the biggest impact. Also things like making cessation programs more readily accessible to people. And so these cessation programs also have to speak in a way that relates to people's lives and the cultural backgrounds that they have and be able to relate to them. And so those are the types of policies, both at the national and local level, that would really help make a difference.
Thank you, Maham. That's a really great perspective. We're getting some questions in the chat. So I had this one. And I think Dr. Chris, you could probably speak to this one from Brooke. She says less than 20% of people are eligible for lung cancer screening actually get screened. And so should screening guidelines be simplified to improve the use of this test? Oh, you're on mute, Dr. Chris.
Yes. Yes, and they have been, Brooke. And so increasingly what you see happening in public health and clinical preventive medicine is examining the data, right, to see if the proposed benefit outweighs the likely harm. And so as we continue to interrogate the data is how we arrived at an adjusted screening guideline. The screening guideline now is such that if you're a person from the age of 50 to 80 and you have as little as a 20-pack year history, you should begin to get screened for lung cancer using CT scans. Okay, that is a difference. That is a change in the screening guideline as we consider the communities that were being disproportionately harmed. The concern is you don't want to expose people to radiation unnecessarily, right? So there was a delay or a pushback in the age and the amount of pack years that made you eligible for the screening guideline to be enacted. So when that screening guideline was changed, and it's more likely that insurance would now cover it for a person to be screened earlier, meaning starting at 50 and at a lower pack year history. One other example of that where that is really pertinent, and I want to always connect the dots for you all, is around breast cancer screening, right? Also, in colon cancer screening, we changed the age at which either a person should definitively get screened or enter into a conversation with their healthcare provider about screening.
Thank you, Dr. Chris. One of the, I guess, additional questions that is coming in is really around um, no menthol buffalo, and I guess this is a takeoff like no menthol Sunday that the Center for Health Equity, Black Health Equity leads in leading the effort to end the sale of all flavored tobacco products across, including mentholated products in their respective cities. How can we partner to implement the Enough is Enough campaign here? And can you talk about the impact of menthol in those with melanated skin?
Hi, Leader Stan. How are you? It's so good that you're on today. I'm familiar with Leader Stan. I'm familiar with the No Menthol Buffalo movement. Leader Stan frequently participates in our monthly Health Leads forums, as does the health chair from New York. So we are very aware of the great work that is happening on the ground in New York. The Enough is Enough campaign was just an opportunity to do additional work than work that was already happening on the ground. You know how these campaigns really come to life. You get specific grant funding. You think about, given the landscape, both the community and the policy landscape, where do you have opportunity to drive a large collective impact? Those geographies that I just reviewed with you were chosen because of things real-time data around what was either happening in a locality or a state legislature, or where we had, let's say, unit or branch assets to execute on the deliverables. And so we will continue to share materials from the Enough is Enough campaign with all of our NAACP branches. Stan, you probably are familiar. We did a presentation back in April of 2025. In addition to that presentation, that was for all leads, right? Back in 2025, where we shared that data with everyone. We will continue to elevate the tools, or let's say the activation lanes and pathways that people use. And then we brought back in Dr. Dartis. Dr. Dartis helped this perimenopausal brain. I think you came in August, was it? For us to revisit this topic. So that's one of the ways, Stan, that we will continue to put this information in front of our different branches, community partners, and to say, hey, this is how you cross-pollinate. Take what was done through this grant-funded opportunity and replicate it in your specific locality or state. That's on that part of the question. The other part of the question is, look, first I want to get at I believe the question was said melanated skin, right? Race is not a biological factor. Race is a social factor. So we know that menthol does not necessarily impact Black or African American persons differently from a physiological standpoint. But we do know from a sociological standpoint, and the point that we made earlier, that menthol is disproportionately placed in Black communities. And this has been an intentional economic agenda, a socioeconomic agenda. That's why the mandate and the mission of the center talks about that socioeconomic approach to whole person health outcomes, right? So understanding that, the center looks to take on industries that enact policy violence against particular groups or populations, because that becomes discriminatory behavior, right? So how are certain products flooded in certain markets, discounting, couponing, sponsoring cultural events, talking about tax issues and things of that nature. That's how we're tackling it. We know that people who smoke menthol products are able to initiate smoking behavior with less harshness because of the menthol and the cooling nature. And then the menthol in and of itself is more addictive. So because products are flooded disproportionately in certain racialized communities, then those persons have different outcomes related to smoking behavior.
Thank you so much, Dr. Chris. Maham, I think this question is from an NACP member, but I think from the policy lens, I would love to hear your perspective. This is actually from Alice Jones from the Fayette County Youth Council in Georgia. And so their question is that many young and old people are not receptive to the current messages of do's and don'ts of tobacco use, and specifically vaping. Policies are ignored by most, so we need to extend these quality messages for them. Can you talk about just access to information and resources that's culturally competent in regards to policy and for decision makers?
And also what's really important here is to have public education campaigns that are culturally relevant and speak to the audiences that they are meant for. And so that requires a lot of money and funding, and requires a lot of focus group testing and those things. And so it's really important that the federal government spend the money here in order to make those audiences that they're trying to target with these messages with quality messages. And so that's how you get that quality messaging, is funding public education campaigns and making them good.
That's great. Thank you, Maham. So I'm going to ask that we jump to two more slides for my team ahead and as a call to action. So one of the things that we are doing here at Truth Initiative in conjunction with NAACP particularly is we understand that the strongest piece is community. We have each other. And so programming like you see today, you're able to do that by joining our coalition, which is called the Breath of Freedom, that particularly focuses on Black Americans. And so a coalition of community leaders who are reclaiming the narrative around tobacco use in the African American and Black communities. We're equipping Black individuals with the tools and educations and communal support needed to quit. And so there's a QR code here today. We want you to join this movement and really give an opportunity to really be in community with us as we do programming like this, create culturally competent resources, and we do this also for the Hispanic and Latino community, as well as the LGBTQ plus QA community as well. And so we want you to be in community with us and really being in partnership and being able to really work off each other to really make sure that we're getting culturally competent information on it. Maham and Dr. Chris has really spoke to that. And really, we want to hear your stories. We want to be in community. We want to give resources and research that really aligns with the things that you want and need to see for your respective communities so you can take action. And so I want to thank both panelists, and I know, Dr. Chris, you have a point of privilege in regards to Acer Health. I want you to have an opportunity to speak about that at this current moment.
Thank you so much, Dr. Darty. So I just dropped in the chat box. Acer Health is a large national public health initiative that the center has been participating in, and we want to always connect these specific issue spaces back to those broader neighborhood level factors that drive health and well-being outcomes. So if you could, please click that link, go to the Acer Health webpage and fill out the every action information that says, hey, I want to stay connected with you. And you will hear announcements, whether it's announcements specific to talk about health AI, and we increasingly have to talk about health AI because it is either already a tool that is being used in diagnostics, screening, personalized medicine, R&D, clinical trials, or through that social innovation range of trying to solution some of the disparities that our communities face, or a comprehensive assessment report that's going to look at a survey that generated almost 23,000 responses to understand those neighborhood level factors that contribute to health and well-being. And recall, you heard me talking about a lot of the social norms and cues that influence or trigger health-seeking behaviors and then other behaviors like tobacco use. And so we want to elevate that information because as you all are in community and thinking through ways to solution and to prevent tobacco use, and to promote nicotine cessation, I want that to be rooted in this very fundamental knowledge that we're learning from across. And then finally, if you want to join us on a monthly basis, please check out our NAACP Monthly Health Leads forums. You can join us. You don't have to be an NAACP member. We get together. We have folks like Dr. Dartis in Truth Initiative, who is a fabulous partner to the center, present and continue to speak truth to to our frontline leaders, and then they take that information and run with it. So I'll make sure I put that in the chat box that's open to everyone. But thank you for the opportunity to share.
Thank you so much, Dr. Chris. Thank you so much, Maham, today. Thank you all for coming out to For Us By Us, really a conversation on Black voices in tobacco prevention and treatment. Thank you so much for coming on and really being a part of this amazing that you will have a survey when you post you leaving the webinar today. We ask that you just give honest feedback so we can make these webinars more tailored for what the things that you want to see. And so thank you so much. We will make sure we get the links out too for Dr. Chris, all the links that she shared, as well as us at Truth Initiative, to make sure that you have an arsenal of things to really enforce in your community. So thank you so much and have a great weekend.